Welcome to today's webinar, Update on Emergency Contraception, Mechanism of Action, Ongoing Contraception After EC, Safety and Side Effects, which is part 2 of ARHP's 3-part webinar series on emergency contraception. I'm Melissa Werner, Director of Education at ARHP, and it's my pleasure to serve as moderator today. Before we get started on our content, I have a few announcements to make. To receive continuing education credit for this activity, you must take the pre and post tests. If you have not taken the pre-test and you are viewing this webinar live, you will find the pre-test link in your reminder email. The post-test link will be sent to you after the webinar. If you are viewing this webinar on demand, both the pre and post-test links can be found below this video. In the webinar dashboard, you should see a chat box that you can use to enter questions throughout the webinar. Our faculty will answer as many questions as possible towards the end of the webinar. In 4 weeks, you will receive an email from ARHP's Education Department with a link to a follow-up evaluation. We ask that you complete this evaluation to let us know how you have incorporated what you have learned into your work. Completing this pre and post test, as well as the follow-up evaluation, helps ARHP ensure we continue to meet your educational needs and interests, and we thank you in advance for your time and feedback. ARHP would like to acknowledge that today's webinar was made possible through an independent educational grant from AFACSIS. On this slide, you will see Planning Committee disclosures. As you can see, Dr. Aisha Mays is a Merck Nexplanon trainer and a trainer for Upstream USA. All other planners have nothing to disclose. As for our learning objectives, by the end of this webinar, we hope you will be able to discuss the following related to emergency contraception, or EC for short, discuss the mechanism of action of EC, offer up-to-date guidance on hormonal contraception after EC, and provide evidence-based information about safety and side effects. At this time, I would like to introduce today's wonderful presenters, Dr. Aisha Mays and Kelly Cleland. Start with Dr. Mays. Dr. Aisha Mays is a family physician who focuses on adolescent medicine. She's the medical director of the San Francisco Department of Public Health Community Health Programs for Youth, adjunct clinical professor in the UC Berkeley UCSF Joint Medical Program, and clinical researcher with the UCSF Bixby Center for Global Reproductive Health / Advancing New Standards in Reproductive Health. Her work centers on the sexual health risks associated with childhood commercial sexual exploitation, adolescent LARC delivery within a reproductive justice framework, and optimizing family planning within the school-based health setting. Kelly Cleland is a researcher at Princeton University who focuses on medical abortion and emergency contraception. Kelly directs the American Society for Emergency Contraception with a mission to improve access to and information about EC to providers, advocates, and the public. Prior to joining Princeton University, Kelly worked at the University of California, San Francisco, and Planned Parenthood of New York City. Without further ado, I'll turn the webinar over to Kelly.
Thank you, Melissa. So our first topic today is a topic that many of us love to hate, which is the mechanism of action of EC. So this is a question that might come up from time to time with your patients, and it certainly comes up in the popular media. And we find that there's still quite a bit of confusion about what EC is and how it works. So when we talk about how any contraceptive method works, the starting question is, when does pregnancy begin? This slide shows a simplified graphic of some of the complex processes that need to happen in order for pregnancy to take place. It's not to scale, but it shows some of the key events that are especially important when we think about EC. So this is based on the mythical standard 28-day cycle, which we certainly know doesn't apply to every woman every month. We start with day 1 as the first day of bleeding. About 12 to 13 days later, the luteinizing hormone, or LH surge, begins. The LH peak is about 8 to 12 hours before ovulation, which in this example happens on day 14. If the woman has sex prior to ovulation and sperm are present, fertilization can happen within the next 5 days or so. Then the fertilized egg makes its way through the fallopian tubes, and within 5 to 7 days, it can implant in the uterus. The mainstream medical definition, agreed upon by such organizations as the FDA, ACOG, and the American Medical Association is that pregnancy begins at the successful completion of implantation only after all of these events have occurred. And right now we're seeing some very disturbing efforts by this administration to change the definition through the HHS strategic plan, and they're redefining their mission as protecting life from the moment of conception. So I think right now this discussion is all the more pertinent. Based on all of this that I've just discussed, a medication or device that works at any point before implantation is a contraceptive. So this is another illustration of how pregnancy begins. Following unprotected intercourse, when the sperm enters the uterus and travels up through the fallopian tubes, it fuses there with the ovum and fertilization begins. This most often occurs in the ampulla of the fallopian tube. Once fertilization occurs, cell division begins and then continues over the next 3 to 4 days before the blastocyst begins to make its way towards the uterus in order to implant. Most people think that implantation occurs on about day 6. This is from IVF data, and it's very, very difficult to determine this precisely in other situations. So now we're going to have an audience poll. And the question is, in the past year, how many patients have asked you about how EC works, in particular whether EC can cause an abortion? And we'll just take a couple of minutes to answer this question, and then after you've had a chance to vote, we're going to sort of see what the consensus is among this group. And then we'll help you address this question if this is something that comes up. Okay, we'll just take a couple more seconds to vote. Okay, so it looks like the majority of folks have had just a few patients ask about how EC works in the past year. 22% of you say no patients have asked about that, and 64% say that 1 to 10 patients have asked about it. There's a few that say that 11 to 25 or more than 25 patients are asking you about this. So even if this is not an issue that's coming up directly in your patient care, it's a good thing to be able to discuss if this does happen in the future. So let's dig into some data around this issue. In 2 important studies, first we'll talk about levonorgestrel EC, or LNG. That's sold as Plan B one-step and many other generic forms in the United States. So in 2 important studies published in recent years, women's cycle days were measured by hormonal assay and ultrasound, not self-report, as has been the standard in many other studies, and which we know is notoriously unreliable. Women were given levonorgestrel EC after unprotected intercourse. And here we show the results of these 2 studies combined. Among 137 women in both studies who took EC before the LH surge, no pregnancies occurred. However, when EC was taken on the day of or after ovulation, the expected number of pregnancies occurred. So this indicates that progestin-only EC has no effect after ovulation and therefore doesn't prevent implantation. And in terms of effects on the endometrium, which is a question that comes up, one study did show an altered endometrial parameter, but this effect occurred when levonorgestrel EC was taken before the LH surge, when we know that it can be effective in preventing ovulation anyway, which makes the question of preventing implantation irrelevant in that case. We can go to the next slide. So in summary, levonorgestrel EC works by preventing or disrupting ovulation, and it appears to be effective only before the LH surge has begun. Once the LH surge is underway, LNG emergency contraception is no longer able to have an effect on ovulation. So therefore, you can reassure concerned patients that LNG EC does not have the potential to end an early pregnancy or prevent implantation of a fertilized egg. The question of whether EC pills have an effect on sperm is still open, and we hope that future research will definitively answer this question. So returning to this graphic, the evidence is compelling that LNG EC works before ovulation and only before the LH surge has begun, so it doesn't affect implantation. From what we know now, it either works before ovulation or it doesn't work at all. So turning to UPA, the mechanism of UPA-EC has not been studied as extensively. some people conflate UPA with abortifacient drugs because it's an antiprogestin like mifepristone, which is an abortion pill. A study published last summer investigated this question of the mechanism of UPA using a similar approach to the previous studies of LNG-EC. And in this study, ovulatory status was determined by menstrual history, ultrasound, and serum hormonal profile at the time of recruitment. Women seeking EC were classified into pre-ovulatory and post-ovulatory groups and given UPA. Among those who used UPA before ovulation, about 78% of pregnancies were prevented. The pregnancy rate in this group was significantly lower than the number of pregnancies that would have been expected given cycle timing. Among women who used UPA after ovulation, only about 36% of expected pregnancies were prevented. The pregnancy rate was no different than would have been expected without the use of EC. So this study is helpful in suggesting that the primary mechanism of UPA-EC is interference with ovulation, and that it may have no effect after fertilization has occurred. Another type of study also tried to answer this question of how UPA works. This was published in 2015, and it's an in vitro study of human embryos in a uterine model. So 10 embryos were exposed to UPA and 10 were not. The number of embryos that successfully attached in each group was not statistically different. Now, this is a small in vitro study, so we can't get too crazy with what we conclude about these data, but it does support the theory that UPA-EC does not have an effect on implantation. And again, returning to our graphic, if we can advance the next slide. It's likely that the additional efficacy that UPA has over LNG is the fact that UPA has a local effect on the egg follicle, and unlike LNG, it works even after the LH surge has begun, but before the LH peak. So we're still talking about a method that prevents or disrupts ovulation, but just does it a little better. And finally, we'll talk about the IUD as EC. So the copper IUD is not believed to have an effect on ovulation, but we know that the copper ions released by the copper IUD are excellent at impairing sperm function and also have an effect on the egg as it moves through the fallopian tubes. So this is the main mechanism of the copper IUD when it's used routinely. It may also have this effect when used as EC, depending on when it's inserted after sex. The near perfect effectiveness of the copper IUD as EC suggests that it can change the environment in the uterus and can potentially inhibit implantation of a fertilized egg. And this mechanism very likely adds to the contraceptive effectiveness of the copper IUD when it's used after sex. So although this question has not been thoroughly studied, we may never know everything about how and why the copper IUD works. Its near perfect effectiveness implies that it could have some effect after fertilization when it's used as EC. But there's no evidence that the copper IUD worked after implantation or disrupts an established pregnancy. So to summarize, the red arrow on the right shows the point where pregnancy begins. All of the EC methods that we've talked about today work before this point to prevent pregnancy. And here are some takeaway messages to share with patients who ask about how EC works, particularly EC pills. First, the best evidence that we have shows that EC pills work before ovulation, but probably not after. Second, if EC pills did work after fertilization by disrupting or preventing implantation, their efficacy rate would probably be higher. And finally, medical consensus is that pregnancy begins once the fertilized egg has successfully implanted in the uterus. No EC methods have been shown to work after that point, so concerned patients can be reassured that EC does not work as an abortifacient.
So now that we've taken some time to think about and talk about how EC works, we'll spend the next few slides talking about ongoing hormonal contraception after EC. So let's start with another audience poll. In your practice, what do you recommend for patients using UPA EC who want to start ongoing hormonal contraception? We'll take a few minutes and fill out our poll. So remembering again that the ulipristal acetate, which is also called Ella by its trade name. So our poll here shows that about half, a little less than half of us in practice take UPA and start a new hormonal method 5 days after use. And then some don't prescribe UPA as EC. And then the others taking UPA and starting the hormonal method right away, which is also the quick start method. And then sort of the last in our poll here is taking UPA and starting a hormonal method at least 5 days after last unprotected sex act. So let's talk a little bit more about the use of UPA and also levonorgestrel EC and how we are implementing that into our practice. So until recently, the general consensus was that an ongoing contraceptive method should be started as soon as possible following the intake of ECP, which includes Ella, so that women don't miss the opportunity to start an ongoing method. But in 2015, the FDA approved a change to the label of Ella, which now says that using Ella, a woman who starts an ongoing hormonal contraceptive method should wait to start that method at least 5 days after using Ella or UPA. The concern is that since Ella is an anti-progestin, following it up quickly with hormonal contraception that contains a progestin could cancel out Ella's ability to inhibit ovulation, thereby reducing the efficacy of it as an emergency contraceptive method. Until recently, a common practice was to quick start hormonal contraception after either kind of oral EC, but a study published last year called this practice into question. So what do we know about contraception after EC? Here's what's known about this issue. A 2015 study considered whether following UPA, which is anti-progestin, immediately after a progestin-containing contraceptive will counteract the effects of UPA. They found that in cycles where women start a placebo pill the day after taking UPA, that there was one ovulation cycle within 5 days. That's 3% in this study. When UPA was followed by a desogestrel, which is a progestin-only oral contraceptive pill, ovulation occurred within 5 days, which is in 45% of those cycles. So normally, if a woman comes into a clinic after unprotected sex and takes UPA, we assume that she's using the most effective oral EC, that it will probably be successful in delaying ovulation. But if that same woman then quick starts a progestin-only pill, there's a good chance that it will counteract the effects of the UPA, and that she might be right back where she started in terms of her pregnancy risk. So we have some remaining questions. These results are really quite compelling, and it does appear that following UPA with the progestin-only pill can compromise the efficacy of UPA. But we are left with some important outstanding questions to consider. Number one being, do these results apply to other pills? We don't have an equivalent pill in the U.S. to this study that was done here, so we can't be sure whether these results apply to pills that are available here. It's important because of how desogestrel pills work. This pill formulation is much better at blocking ovulation than other progestin-only pills, so perhaps the effect of UPA might be different if a different pill was used. Our second question to ponder, does this apply to other hormonal contraceptives? If Mirena or the implant or Depo were studied this way, would we also find the same efficacy of UPA being compromised? A next question we should consider, should we be thinking in terms of time since UPA was taken or time since unprotected sex occurred? Since sperm are not viable after 5 days, perhaps we can change the recommendation to read 5 days since unprotected sex occurred. And then finally, given the risks given that we don't have answers to these questions right now, how do we weigh competing risks? What is more important, the potential loss of efficacy versus the opportunity to start an ongoing method? We can advance to the next slide. So when we think about how we are going to ponder these questions and how we will implement this data into our practice, one thing we really want to be cognizant of is ruling out pregnancy. So on the next few slides, we'll talk about providing long-acting contraception after EC. First, let's talk about what it really means to be reasonably certain that a woman isn't pregnant. You can be reasonably certain that a woman isn't pregnant if she has no signs or symptoms of pregnancy and meets one of the following criteria. These guidelines come from the CDC Selected Practice Recommendations for Contraceptive Use. For EC clients, the key criteria are those in red on this slide, since we can probably assume that a woman presenting for EC has had unprotected sex recently and is not using a consistent contraceptive method. Once you confirm that she doesn't have signs of pregnancy, find out if she is within 7 days after the start of her period, within 7 days of a spontaneous or induced abortion, or within 4 weeks postpartum, or fully protected by lactational amenorrhea. If you are not able to rule out pregnancy, you can use these indicators and offer a pregnancy test. So the CDC Selected Practice Recommendations on Contraceptive Use offers these recommendations for women using UPA-EC. In general, hormonal contraception should be started no sooner than 5 days after taking UPA. Non-hormonal methods, including a copper IUD, can be started right away. Although remember that the copper IUD is the most effective EC method on its own, so if you're using a copper IUD, there's no need to use any other form of EC. For methods that require a visit to a provider, such as the levonorgestrel IUD, an implant, or the shot, there's often the concern that a woman may not be able to return to the office or clinic in 5 days after taking UPA. The CDC guidelines state that for these methods, providers can consider offering the method on the same day, but must weigh the risks of potential loss of efficacy with the future risk of pregnancy posed by not starting an ongoing method. And then finally, the CDC recommends use of a barrier method of contraception or abstaining from sex for 7 days after the use of UPA for those who are starting a new method. So an alternative set of recommendations is offered by the American Society for Emergency Contraception. These recommendations have been rigorously reviewed by a panel of experts and provide a different framework for providing EC and hormonal contraception that you can customize based on your patient's needs. These guidelines encourage providers to consider the following with their patients. First of all, whether UPA-EC is even available. Although UPA is approved in the U.S. in 2010, it's available only by prescription and is still not consistently available at all pharmacies. That's what we saw in our poll at the beginning of these slides. Next, ask about the patient's cycle day and the timing of sex, and consider whether the patient is at greater risk for pregnancy from the active intercourse that just occurred or from future acts of intercourse. Next, you want to find out if she's interested in ongoing contraception and whether she is likely to return for a follow-up visit within a few days. If she wants a provider-dependent method like a hormonal IUD or implant. And then finally, be sure to ask whether she needs EC because she missed or was late in using her pills, patch, or ring. So these are multiple things to consider, and we'll go through them. So based on these answers, you can recommend one of two approaches. So first we'll talk about approach number one, which is providing UPA plus ongoing contraception. This approach is a first choice option when UPA-EC is available and the patient is either, number one, at high pregnancy risk from the previous active intercourse, number two, interested in ongoing contraception and willing to come back for a follow-up appointment, or number three, not in need of EC because of missed or late pills, patch, or ring. So what we will do with approach number one, again, UPA plus ongoing contraception, once you and the patient have determined that this is the right approach, you're going to provide UPA-EC, talk to the woman about which ongoing method is right for her. If she wants to use a pill, patch, or ring, You can either provide the method if you have it in your office, which is most desirable, or give her a prescription. Have the patient set a reminder on their phone, on their calendar, whichever they use best, to start the method 5 days after her last episode of unprotected sex. Or if she's taking the pill, she can use her placebo pills and then have her start those right away. If she wants to use the implant or injection, make an appointment for her to return for the method no sooner than 5 days after she had her last unprotected sex. Since we believe the sperm are only viable for 5 days, we recommend counting from the day of last unprotected sex rather than the day UPA was taken. And if she's interested in the levonorgestrel IUD, offer it within 5 days if you can reasonably rule out that she's not pregnant on that day. And then you want to counsel her to use a backup method, abstinence or a barrier method for 7 days after taking UPA. And now we'll talk about approach number 2. So this is a second approach in offering the levonorgestrel EC plus ongoing contraception. Obviously, if UPA is not available and if your patient does not want a copper IUD, this is the next option for EC. However, there are other criteria that make this option preferable for some patients. For example, this might be the better approach if the patient is, number 1, a relatively low pregnancy risk from the previous active intercourse because of when in her cycle she had sex. Number 2, interested in ongoing contraception but unlikely to come back for a follow-up appointment. Or number 3, and importantly, if she needs EC because of missed or late pills, patch, or ring. This last criterion is really important because many women present for EC because they missed pills. Until more research is available about the interactions between the different formulations of UPA EC, it's prudent to avoid mixing UPA and pills, so offer the levonorgestrel EC to these patients. This would also be pertinent for missed ring or missed patch. So in terms of implementation of our second approach, once you've settled on this approach, you provide the levonorgestrel EC and talk to the woman about which ongoing method is right for her. If she wants to use a pill, patch, or ring, either provide it in the office if you have it, or give her a prescription and tell her that she can start it right away. Similarly, if she wants to use the implant or injection, you can provide it immediately. And if she's interested in the levonorgestrel IUD, you can provide that on the day if you can reasonably rule out pregnancy. So you would provide the levonorgestrel IUD with the levonorgestrel EC. And then, of course, you want to counsel her on using a backup method for 7 days, which would be abstinence or a barrier method after taking levonorgestrel levonorgestrel EC. And then now in terms of contraception after EC. So as we've noted, more research is needed before we can clearly understand how different progestin-containing hormones do or do not affect the ability of UPA EC to suppress ovulation. In the meantime, here's some basic messages to keep in mind when working with patients. First of all, you don't want to mix progestins and antiprogestins. Until we know more, it's best not to start a progestin-containing contraceptive method at the same time that UPA is taken. You want to consider whether pregnancy risk is greater from sex that already occurred or if it will be greater with future sex. Consider whether the patient is willing and able to return for a visit to provide a long-acting method or a provider-dependent method. Finally, if your patient needs EC because she missed or was late in starting her pills, patch, or ring, we recommend the levonorgestrel EC instead of UPA EC.
Great, thank you, Dr. Mays. So next we're going to just address some very common concerns that may come up about safety and side effects. And I just want to note this is a very brief overview. If there are any topics that we touch on here that you'd like us to cover in greater depth, we have one more webinar in this series that's going to be a frequently asked questions format, and we'd be very, very happy to explore some of these topics in greater depth. So the first page of our overview on safety, ECPs are extraordinarily safe, and they very clearly exceed the requirements for OTC availability. The advantages of ECP use generally outweigh the risks, even for women who have contraindications to ongoing use of estrogen-containing contraceptives, things like vascular disease, migraine with aura, or severe liver disease. For these women, use of UPA or progestin-only EC is safe. The duration of hormone exposure, although it's higher than that found in oral contraceptive pills, is brief and entirely safe. And I think this is really important to keep in mind, particularly when we think about messages that are out in the media about EC, because you often see comments like, EC is a massive dose of hormones. Certainly it's a higher dose of hormones than what you would get in an ongoing contraceptive pill, but it's a very, very safe method. So next, I also want to emphasize there are no medical contraindications to the use of EC for patients of any age except pregnancy. And the reason that pregnancy is a contraindication is because if someone's already pregnant, treatment will be ineffective, but it won't harm a pregnancy. And I want to point out that in the U.S., the labeling for levonorgestrel EC and for UPA includes only one contraindication, and that's known or suspected pregnancy. Next, I want to point out there is no increased risk of birth defects following use of EC. ECPs also do not increase the chance that a pregnancy following ECP failure will be ectopic. And in fact, ECPs lower the risk of ectopic pregnancy by preventing pregnancy in the first place. Finally, you can reassure patients that EC use will not affect their future fertility. This is a question that people, may bring up often, and people may think there's a limit to the number of times you can use EC. There's not. It's not going to affect their fertility, so you can reassure patients about that. So on to side effects. Generally, EC side effects are not serious, and they generally subside within a day or two after treatment is completed. Common side effects include headache, fatigue, menstrual disturbance, nausea and vomiting, breast tenderness, and abdominal and back pain. Women also may experience a shorter or longer menstrual cycle depending on when in the cycle ECPs are taken. So it's really important to counsel patients to know that they should expect changes in their next period, and it may not be predictable exactly what those changes will be. It's also helpful to point out that both levonorgestrel and UPA EC has a lower incidence of nausea and vomiting than what we see in use of the Yutsby regimen. And as a reminder, the Yutsby regimen is using combined oral contraceptive pills in larger doses as EC. A question that may come up frequently is whether breastfeeding women can use EC. And here are a few guidelines to help reassure your patients. So first, when it comes to levonorgestrel EC, there are no restrictions on the use of progestin-only EC by breastfeeding women. This means that your breastfeeding patients can use EC with no interruption in breastfeeding, no need to pump and dump. Turning to UPA, although the U.S. label for UPA doesn't recommend that breastfeeding women use it, research shows that it is suitable for breastfeeding women. Guidelines vary as to whether users should express and discard their milk for 24 hours or 1 week, but either way, you can reassure patients that it's okay to use. But an important takeaway here is that patients should be reminded that they may not even need EC if they're exclusively breastfeeding and their baby is less than 6 months old and they haven't had a period. EC may not even be required because lactational amenorrhea may be doing a great job keeping them from getting pregnant. And a few notes about potential drug interactions for EC users. We discussed earlier in Dr. Mays' presentation the potential interaction between UPA and progestin-containing contraceptives. There are also other medications that could reduce the efficacy of EC. And first, we want to talk about hepatic enzyme inducers, including things like rifampicin, some anticonvulsants. Women using these should be warned that the efficacy of EC pills may be reduced because enzyme inducers can increase the metabolism of both LNG and UPA-EC. So for these patients, the first-line option for EC is the copper IUD. For patients for whom the copper IUD is not acceptable, not available, not affordable, for whatever reason, not the right choice for them, a double dose of LNG, that's 3 milligrams, is recommended. This approach is safe, but the efficacy isn't really known. A double dose of UPA hasn't been studied for this indication, and it's not recommended at this time. And finally, I want to turn to the safety of the copper IUD. Copper IUDs used as EC generally follow the same protocols as for routine use. There are no medical contraindications for the emergency contraception of a copper IUD except pregnancy and active PID. Women who are at high risk of STIs, which may be the case among EC users, these women can be screened and treated for STIs at the time of insertion. And finally, I also want to point out women of any age or any parity should be considered candidates for an IUD. I think there's a lot of sort of older protocols and older thinking that suggests that nulliparous women and young women shouldn't be using IUDs. I think most of us probably now agree that that is no longer relevant. For breastfeeding women, they should be counseled that the risk of uterine perforation is a bit higher than among women who are not breastfeeding, but still the absolute risk is very, very low. One study found 3.7 perforations per 1,000 insertions among breastfeeding women, so I think that seems very reassuring. That's all we have about safety and side effects. Again, if there are any of these topics you want us to cover in greater depth, please let us know in the chat feature. And now Dr. Mays is going to close us out with a case study.
So let's just review this case here. So we have our patient, Maria, and she's 35, and she had unprotected sex 48 hours ago. She has heavy periods. She does not want a copper IUD, and she would like to start the levonorgestrel IUD. How would you all proceed? So with Maria, our questions that we'd want to ask, can she come back in 5 days after having unprotected sex? That would be 3 days from now. So no, she has a hectic schedule, balancing work and children. Can we reasonably rule out pregnancy on the day of her visit? The answer would be yes. She started her period 6 days ago. So we decided to provide the levonorgestrel IUD that day. We gave her levonorgestrel EC, and again, we want to remind her to use condoms or abstain for the next 7 days. So in summary, so we want to remember that all EC options are contraceptives. They work in balance. They work before pregnancy is established. Ongoing hormonal contraceptives should not be started within 5 days of unprotected sex for UPA users. You want to consider pregnancy risk and desire for ongoing contraception when recommending an EC pill. ECPs are extraordinarily safe, and overall the benefits outweigh the risks in all situations. And here are the references that we used to support all of the talking points here in our webinar. And if you would like additional resources, you can find additional information on bedsider.org. This is great information for providers and for patients. The American Society for Emergency Contraception, and then nottolate.com also has great patient and provider resources.
Thank you so much, Kelly and Alicia, for that excellent presentation. And we're going to go ahead and move on to some participant questions. Please do go ahead and type your questions in the questions box so that we can address them. Okay. So first, we've got a question from Andrea, who says, just to clarify, based on the US MEC, after someone takes UPA as EC, the recommendation is to pump and dump breast milk for 24 hours after taking it? It sounds like she's asking for confirmation that this is correct. Aisha or Kelly, would you like to address that?
Yes, I'm sorry, I was on mute. Okay. Yes, that is a recommendation from the US MEC at this time. It has not been updated on the label. Aisha, do you want to say anything about how you counsel your patients on that?
Yes, so will you repeat the question because I can't see them here on the panel, and I just.
The question is
Sure.
about use of UPA in breastfeeding women. The U.S. medical eligibility criteria recommends that women pump and dump for 24 hours after use of UPA.
Yeah, so that is something that we follow in practice, and again, it's because we are studies are still out on UPA, and until we know more information, it's consensus practice that it likely is safe, even with breastfeeding, but because there is not enough information to give a strong recommendation until we have more information and more research. Our current recommendation is to pump and dump for 24 hours.
Great, thank you. We have a question from Amy who asks, why can you provide a progesterone IUS at the same time as Ella? How is this different than waiting 5 days for a combination BCM after Ella?
So this is Aisha. So I think that this is the same sort of decision tree that you really want to make with your patients about whether they will be able to come back in 5 days for their ongoing method. And having that decision tree, you want to think about when was the last unprotected intercourse, and are they more likely to become pregnant from the last unprotected intercourse or more likely to become pregnant from future intercourse, and really having that conversation with the patient. There are some preliminary studies on the use of the levonorgestrel IUD as an AC method. That those studies are still in the works, and so we're really looking forward to the results of that research, but there is some ongoing work in that field as well. But just thinking about that decision tree around what makes more sense in terms of the patient's access for the method of their choosing at the time that you're seeing them for the EC visit.
And Melissa, I just want to clarify, was the question whether we're recommending use of UPA and an immediate start of a levonorgestrel IUD?
Let's see, why can you provide a progesterone IUS at the same time as Ella?
Yeah, so I think that's not, thanks for clarifying that. That is not the recommendation. The recommendation is if you're providing levonorgestrel IUD to wait if the patient is taking Ella that day.
Okay, thanks for that clarification. We have a question from Teresa who asks, some of my patients at a free clinic are substance users, alcohol and non-prescription drugs. Since long-term alcohol use affects hepatic metabolism, what EC do you recommend?
Aisha, do you want to take that?
So I think if we think about, so this would really be the opposite of instead of it being sort of a rapid inducer, which came up in the webinar, we would be thinking about sort of delayed metabolism, and I think we have to think about in terms of overall use of progesterones, and it may be safer to, that I don't want to misspeak out of the evidence, and so going back and thinking about what is the evidence for those with liver disease, and thinking about sort of what the recommendations are for the MEC with ongoing methods. I think it's something that we probably should look up before we give a definitive answer, because I don't want to give you a recommendation that's not evidence-based.
That may be a good thing to address in our frequently asked questions webinar next month.
Yeah, I agree with that.
Okay, so Anne would like to know about the case study. She's stating that the woman had intercourse on day 4 of menses, and she's wondering why she needs EC at all.
Well, EC should really be provided within 96 hours of unprotected intercourse. So You may see on the package insert, they may say up to 72 hours, but really practice is really to provide it within 96 hours or 5 days of unprotected intercourse. So if you have patients who come in and have had an unprotected sex act within 5 days, you really want to offer them EC, have a conversation about emergency contraception.
And I think, I'll just add here that this patient, I think the question may be motivated by the fact that this patient probably is not at high risk from pregnancy from that active intercourse. But I think, we get a lot of questions on the Not Too Late website from women who are coming from a place of an abundance of caution. They're really concerned, even if they're not at really high risk for unintended pregnancy from the sex that just occurred, they may still want to have that reassurance of getting an EC method. And in this situation, since the risk of pregnancy from the sex that just occurred isn't terribly high in this, and because that patient said she could not easily come back for a follow-up visit, in this case it makes sense to do the levonorgestrel EC and then provide the levonorgestrel IUD right away. For a patient who has a very high risk of pregnancy from the sex that just occurred, it might be a different calculation, and you might want to prioritize UPA. Or in a case where the patient has a high BMI, because we know that UPA is more effective than levonorgestrel in that patient population.
I think this is also where we have to also think about our adolescent and young women population, where their fertility is can be less consistent and maybe harder to gauge with our sort of standard fertility norms. And really making sure that if they are within the window, the 5-day window of providing EC, that we do provide that, because it can be less certain with younger populations.
Thank you for that. And related to BMI, we actually have a question on that topic from Amber, who asks, how much should the BMI weight of the patient be factored into what EC method is given?
I'll just start this, and then I'd like to hear from Dr. Mays also. I think this is, it's a really complicated equation when we're talking about EC, and I think, if you factor in how long it's been since she had sex, and more importantly, where she is in her cycle, the weight issue, becomes, I think, even more important for a woman who is closer to ovulation, because then the effectiveness of the EC is even more important. But it's really a balancing act with, the patients that you work with to understand what risk of pregnancy is she at from that sex that just happened, and BMI is very much a part of that equation, versus how much, can you help her prevent future pregnancy by giving her a method that will really work for her. Dr. Mace, do you want to say anything else about that?
Yeah, I do. I agree with that. I think that it is a fine balancing act, and I think that the weight conversation and some time restriction can make it even more confusing, because we know that both EC pill methods only work at a certain time during a woman's menstrual cycle. So it's sort of knowing where she is within her menstrual cycle, knowing that she has regular menstrual cycles, which may or may not be the case for younger patients, and then also weighing the risk of ongoing contraception in terms of which method you're going to be choosing. I think sort of in my practice, I try and have some standards around preferentially talking about and being able to provide UPA or the copper IUD for my higher BMI patients, using the levonorgestrel EC pills for lower BMI patients or patients who I'm going to start an ongoing method, and also knowing that that's not a sort of a magic combination, because it is sort of weighing several unknowns at the same time.
Sounds like a fairly complicated but important decision, so thank you for that. We have two questions from Holly. I'm glad she was paying so much attention. One question is for the patient who is already on OCPs and has missed several doses and wants to take EC due to unprotected intercourse. Does she wait 5 days to resume OCP?
I think the recommendation that we came to on this was that for patients with missed pills, because there are so many unknowns about the interactions between ongoing contraceptives and EC methods, that we would recommend levonorgestrel EC for that patient, and she can start her pills right away. If you start UPA, it just sort of brings in some concerns about whether there's going to be interactions there. So it's probably just easier to start do the LNG AEC and have her resume the pills. She also, frankly, may not be at much risk at all of pregnancy, if depending on how many pills she missed and what pattern, where she was in the cycle. Aisha, what do you think about that?
Yeah, I mean, I completely agree with that recommendation. I think if you are in a situation where the patient is at high risk for pregnancy and doesn't want to change their method to a copper IUD, and you have access to UPA and want to do that, an alternative with support is providing UPA on that day, talking to her about restarting her pills within 5 days, and maybe giving a phone call if you have an MA who can call or a nurse who can call to remind the patient to start the pill and to start the pill in a correct way. Again, that's another step, but if you're not going to be using the levonorgestrel EC pills, you want to provide some more patient support around restarting the birth control pill. So that would be my recommendation.
Thank you. Holly was also interested in knowing or asking you to speak to antibiotic use and any interactions with oral EC options.
Yes, so I think overall we know that the antibiotics don't interact with any of the oral EC pills. There used to be thoughts that antibiotics interacted with combined oral contraceptives and other types of combined hormonal contraceptives, and we know that that's not the case either. So completely safe and not worried about contraindications. Again, we did talk about tuberculosis medications like rifampin, but with the antibiotics, not a concern.
Great, thank you. We have time for another couple of questions, and I see 2 more here. So if anybody does have some last questions that you want to make sure we get in before the end of the webinar, please do type those in now. Alicia asks, what are your thoughts about how soon UPA will be stocked in all pharmacies, and also if there's any chance of it going over the counter anytime soon?
Oh, I would love to answer that question. So yeah, UPA, the state of stocking of UPA in pharmacies is pretty terrible. We had a great presentation at the ASEC annual meeting, which is called the EC Jamboree, a couple weeks ago by Jennifer Salcedo from the University of Hawaii, and she found in a nationwide survey of pharmacies that only 21% of pharmacies had UPA immediately available that day. It's a huge problem, and what we hear from pharmacists is that it's sort of a circular problem, so that they're not stocking it because doctors aren't calling it in, and all health care providers who can prescribe are not calling it in, and then prescribers aren't calling it in because their patients are reporting back that it's not available in stock. So I think this is something that you all as healthcare providers can improve this by having a relationship with a pharmacy in your area, calling that pharmacist and saying, look, this is a product that my patients need. I will be calling in prescriptions for it, but I'm only going to call it in to you if you can promise to stock it. So I think that's sort of where it has to start with those conversations. I think I still find it a little shocking that 7 years after approval, availability is so poor. And in terms of it going over the counter, they're trying. I think I think it's important to know that this is an effort that is underway. Ella 1, the European brand, is available OTC throughout Europe, and it's really, I think it's had a great effect on use. So we're hoping that that can happen in the United States because, I think Ella is a better product, but it is really underutilized, and it's a huge problem. Aisha, do you want to say anything about that?
Yeah, I completely agree with that. Some of the efforts that we've made in our clinics. I mean, I'm located in the Bay Area, and we've noticed that we also have difficulty with Ella being stocked in the pharmacies, and something that we have done locally within our clinics is the same thing that Kelly just mentioned, specifically reaching out to the pharmacies and letting them know that this is something that we're going to be prescribing and it's really important, and generating prescriptions to particular pharmacies to encourage the pharmacies to then stock it. Some of the issues around pharmacies not stocking particular medications is that they may be expensive and then they expire. So if you can start with working with a few of local pharmacies that your patients access, that may help to start to generate the medication in the community and can spread out further into the city.
Thank you so much for that. And our final question is from Steve, who asks, what accounts for the increased risk of uterine perforation with IUD insertion among breastfeeding women?
You want me to take that one, Kelly?
I think it's due to the thinning of the endometrium. But again, it is not, but I'm happy to look into that more because the mechanism is not something that I know a lot about. But I would just emphasize with patients that while the risk is increased, the absolute risk is still very, very low. And a skilled provider, it shouldn't be something to be terribly concerned about. So like Kelly said, it's the thinning of the endometrium from just and also the thinning in addition to the contraction of the uterus that happens with breastfeeding. So oxytocin causing the contraction, the milk let down, but also the contraction of the uterus. So you have a thin uterus that's also contracting, and so that can cause increased risk of perforation, but overall the absolute risk is still low. So it's not something that would cause a contraindication to use.
Fascinating. Thank you. I appreciated that answer as well. And I would like to thank both of you again, Aisha and Kelly, for joining us today. And I also would like to give Kelly Cleland a shout out for serving as the fabulous consultant project manager for this entire program. She's done a wonderful job. Before we exit this webinar, I'd like to remind folks of a couple of things. As I mentioned earlier today, today's webinar was the second in a three-part series. The first webinar is already available on demand for viewing on our website, and the third webinar, which will be an FAQ webinar, will take place on November 20th. You can sign up for that and access these and other resources on many other topics at arhp.org. As a reminder, please be on the lookout for an email from ARHP's Education Department with a link to the post-test survey. Your CME or CE certificate will be generated at the end of the survey, and please be sure to print the certificate before closing the internet browser. If you have any questions, please do email us at education@arhp.org. I'd like to thank you for taking the time to participate in this webinar, and we hope you will take part in other ARHP-sponsored educational activities in the near future. Have a good afternoon.